heavy smoker or drinker. I didn't expect anything like this. It came as a complete shock when I was told it was cancer.
We know that our survival rates in this country are poor in comparison with those in other developed countries, and we know that if we achieved the levels of the best, we could avoid around 10,000 deaths each year, and it would be 5,000 deaths even if just reached the European average. To do that, we need to get patients to come forward sooner. We need to support GPs to know when to investigate and when to refer. And we also, of course, need to make sure that patients get the best treatment. But we really can make a difference here, and we're committed to making a difference over the next 2 to 3 years.
Head and neck cancers cover cancers in the mouth, the nose and the throat, and they arise from the squamous cells that line the mucosal surfaces in these areas. The symptoms for these cancers are common. You will see them all the time, but the disease itself is rare. If we can diagnose these cancers early, this will lead to better outcomes for our patients. Focusing on risk factors and red flag symptoms makes for an easier and more appropriate referral. Key items to be aware of are lifestyle factors and the persistency of symptoms.
I was having problems swallowing when I was eating. Occasionally, I would have to get up and have a drink or even get rid of whatever food I'd eaten because nothing was going down. I saw a practice nurse. She looked in my throat, couldn't see anything wrong, didn't examine my neck, but she thought it was just, I was getting over perhaps a cold or something like that. But a couple of weeks later, it still didn't feel right when I was eating or swallowing. So I made an appointment to see another doctor. He thought it was my sinuses that was giving me the problem and gave me a nasal spray, which did not work at all because I knew it wasn't nasal. So I made an appointment again to see a doctor, and I saw this locum doctor that he looked at my throat, examined around my neck, and he decided then that I needed to see somebody else.
Talking about risk factors for oral cancer, I would divide them into primary risk factors and secondary. Primary risk factors mainly are age, which is more common in people in the 60s and 70s, and being male. The other primary risk factors are genetic factors, like family history or previous history of having a cancer. The secondary or avoidable risk factors are smoking and drinking. If you have a combination of smoking and drinking, it increases the risk exponentially by about 35%. The risk for pharyngeal and laryngeal cancers are very similar to oral cancer, except for hypopharyngeal cancer, where the risk is much higher if you consume spirits like whiskey rather than beer. Thyroid cancer, in contrast to oral or laryngeal cancer, is more common in women and in a younger age group, typically between the 30s and 40s, and the risk is increased if you have a family history or previous history of radiation exposure.
Oral cancers are increasing, but the important change is a shift from older men with high tobacco and alcohol usage to a younger group of patients, both men and women under the age of 40, who have oropharyngeal cancers, which are driven by a virus, HPV-16, which may be sexually acquired. The key message here is that these HPV-driven oropharyngeal cancers have an excellent prognosis and should be regarded as a separate disease entity.
I was driving my car when I discovered a small lump in my neck. I called my GP straight away and went to see them. I'm actually a pretty fit, healthy guy, do a lot of cycling, I do some running. I was not feeling unhealthy, I didn't feel unwell. I went to see my doctor. He was a locum. When he examined the lump, it was soft, it was malleable. He did not have any concerns. He did think on balance it would be worth referring me to a specialist, and I'm obviously now extremely pleased that he did.
We're dealing with common symptoms, but symptoms that may persist for up to 3 to 6 weeks. For example, if we have a patient who finds it difficult to swallow, a hoarse voice, as well as a persistent cough, this patient is likely to have cancer in the head and neck rather than lung cancer. If the patient has all the risk factors and his symptoms persist, it is very important to examine the oral cavity thoroughly. Essentially, we need to look and feel for the lining or oral cavity. The most common appearance of a mouth cancer is a single or solitary ulcer. The edges will look irregular and is raised or rolled up and is very, very tender to touch. It can also bleed very easily, and compared with the surrounding tissues is very much harder.
Examination of the neck and thyroid begins by inspection. Make sure you have the patient's neck adequately exposed, right up to or below the clavicle. What we're looking for is any scars from previous operation or any evidence of an obvious neck lump. To examine the thyroid, it's a good idea to get the patient a sip of water. And can you take a sip of water in your mouth and hold it until I tell you to swallow? Thank you. Can you swallow now, please? So when the patient swallows, if there's a thyroid swelling, you will see the swelling move up and down with the swallow, indicating that that is a thyroid swelling. The examination of the neck is best done in a systematic manner, starting from the superior aspect of the neck, anteriorly going inferiorly into the supraclavicular fossa. You can either do one side at a time, or you could do both sides at one time. So we start off with the submental triangle, followed by the submandibular triangle, the upper jugular digastric chain, the middle jugular digastric chain, and the supraclavicular fossa. We also examine the occipital lymph nodes and the posterior triangle to ensure there are no palpable masses. And what we're looking for are any abnormal lymph nodes which feel firm and fixed to the underlying structure, which would indicate metastatic node.
Please bear these key messages in mind. Refer early where appropriate, as early stage disease has an excellent prognosis. And please do use the 2-week wait guidelines.
Following the correct guidelines on the form can lead to improved outcome and avoid inappropriate referrals.
Following a referral for a suspected head and neck cancer via a 2-week wait, a diagnosis is reached typically after multiple imaging, biopsies under local anesthetic, and occasionally under general anesthetic with endoscopy. We have a specialist head and neck and thyroid clinic where we can provide a full range of diagnostics and treatment. Once the diagnosis is made, the patient is discussed at our MDT, where various medical and surgical teams are available to formulate a diagnosis and then follow the patient's progress after treatment. Treatment for most forms of head and neck cancer could have a long-lasting effect on functions essential for our day-to-day living, like sleeping, breathing, talking. This could mean a devastating effect for the patient and for the carers, and therefore they require expert support before, during, and after the treatment.
I weren't very good when I first came home, but it takes a while to build up confidence to be able to do it. But I was determined to make sure that my life wouldn't be altered too much.